Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking about addressing the chronic disease crisis, the foundation of making America healthy. This panel discussion was recorded live on May 2nd at the event Primary Care 25. Let's get started.
First of all, thank you all for taking the time. I know you're all busy. Wanted to set the tone for the conversation. I don't want to focus so much on the what, but more about the how, that we've got here with America on America's health journey. So I'd like to start off with, we know all the statistics. Chronic disease is swallowing up the country's health and wealth. But before we get into all the policy and the data, I'd love to ask each of you, especially for our listeners who are medical students and residents, what was the moment in your own journey where the crisis hit home for you personally or professionally? So we could start with you, Dr. Shin.
So before I was at the National Association of Community Health Centers, I was a young researcher at the George Washington University. And one of my first projects was to look at family planning services, looking at reproductive health. And going out into the field, we were also studying healthcare contracting. Medicaid managed care was just coming into the fore. And when we're looking at the rates, guess how much rates were for contraceptive services? 25 cents is what we found at that time. So I think that just sort of lit a light bulb in terms of, that we just needed to know more about this kind of unraveling, as well as some of the defining issues. But sort of just going back to the issues of chronic care, I think, we also heard when we were in the field a lot of stories of families who were talking about how their parents or grandparents were basically deciding to die at home and not go to the ED or hospitals because they couldn't afford care for their diabetic or heart disease issues or even prescriptions at that time.
Hi, everybody. I'm Kate Goodrich with Humana. My story is sort of mostly personal, a little professional. So I'm a hospitalist in addition to working at Humana. And I worked as a hospitalist full-time for 10 years and then went to do a career in policy. And at that same time, my mother came to live with me. And it was because she had a whole bunch of chronic conditions and needed help caring for herself. And you think after 10 years being a hospitalist, seeing mostly seniors or everybody who had multiple chronic conditions and were in the hospital because of complications of those chronic conditions, that the crisis would have hit me already. But where it really hit me was when I became the care navigator for my mother. And over the 14 years that she lived with me, she developed more conditions, I've heard the statistic that I think maybe came out of AAFP, which is that seniors with chronic conditions see 7 clinicians in 4 different health systems on average. And for my mom, it was 7 and 7. And so the navigation was perilous at every moment. And it really affected me to understand what people, especially seniors, which is the population I focused on in my career, go through just to get by. She took 19 medications at the time that she passed away. And she was in the hospital the last few years of her life 4 to 5 times a year. And she actually had a wonderful primary care doctor, but in a terrible primary care system. And I really mean the national system, not so much just the singular system she was in. So that's when, I could really, also going into policy at the same time, really sort of put together the pieces of what it's like to care for these people, what the policies are that make it hard, and what the policies are that make it hard not just for clinicians like myself, but for the patients themselves. And that's when it really became a purpose for me to focus on that area.
Yeah, so I was in the fortunate situation in the first 20 years of my career to be practicing in a military system that at that time was not using RVUs as an accountability measure. And I had a panel of patients, diverse from retirees down to kids. I knew them. I knew their families. I knew what their families wanted for the older individuals in those areas. So I knew that when Mrs. Jones, 89, with major heart failure and a huge heart on a chest x-ray, ended up fainting or falling and going into the emergency room, they would call me instead of actually admitting her, which doesn't happen anymore, okay? Because if she had been admitted during COVID, it's more likely she would have died than survived that. And so the residents were running this community hospital, and it was very satisfying to be able to know what needed to be done and how to communicate them instead of finding out, oh, she'd been admitted and the family couldn't see her, which happened to many people later on in those areas. When I got out of the military, I actually started to get engaged in more civilian sectors, and it was a wake-up call. It was a huge wake-up call. And so I said, I'm going to volunteer my time and just go back and see patients in the military where I can have that. And I've noticed over the next 20 years, yes, I've been practicing that long, the next 20 years there's been an erosion in whole person care where we were charged with not just taking care of diseases, but keeping people healthy. And in the military, you're supposed to keep them optimally performing, right, in those areas. And that means prevention. It means trying to reverse chronic illnesses if you can so that they can perform. Or if that can't be done, keeping them well, keeping their well-being going through managing things like you just described in those areas. And now, even in a capitated system like that, they're using RVUs to do it. And you can see the immediate erosion in the ability to actually take care of chronic disease in those areas. So that's been sort of my fortunate and unfortunate view on what type of primary care is needed. And I think it's very important that we pay attention and focus on what type of primary care, not just cast an umbrella all over all of primary care and say fund it all. That is not going to work, and it's not working.
The light bulb moment came in third year of medical school, where I was working with our internal medicine service. I was in the hospital. I was admitting somebody that I had admitted a couple weeks prior, and it was a readmission. And this person had really bad heart failure, really bad diabetes. Their feet didn't fit into their shoes anymore. They were blind from diabetes. They struggled with housing. And I looked in their chart, and I was putting together their history and realized this person had been admitted 8 times in the last year for really the same thing. And it was like watching a movie over and over and over again as I read through this chart and realized this guy's story is he's spending these last years of his life in and out of the hospital for the same thing. And when I was talking with him about the plan, I said, I don't want you coming back to the hospital. I want you to get well. I want you to have a better life. And we were making plans on what to do upon discharge. I said, who's your doctor? And he said, I don't have one. I said, have you ever had one? No. Nobody knew him. Nobody knew him in a primary care sense. And I think that was a moment for me that really brought home the importance of having a relationship with someone that knows the patient and can work with them and provide that whole person care.
Especially with how you finished, I want to ask Dr. Jonas, when he ended with talking about whole person care, when we say making America healthy, what does that look like to you in a clinic, in a home, in a neighborhood?
So the phrasing is great, okay? Reduction of chronic disease is great, okay? Primary care, as I mentioned earlier, as an umbrella aspect, is not going to do it. It's not a matter of more money into primary care. It's about more money into a type of primary care that can actually reduce chronic disease and make it healthy. And I think the public doesn't understand that. We know, a recent survey showed that the public, and I think most politicians, probably think, oh, gee, 50% of the budget must go into what they call primary care, okay? But not that type. And we know that the kind that we're talking about in this room is, less than 5%. So there's a real misunderstanding about the type of care that we need to reduce chronic disease, which is what we're talking about. That's whole person. It's relationship-based. It's grounded in relationships. You cannot change behavior, lifestyle, compliance, whatever you want to do unless you know the person and they trust you so that they're engaged in their own care. And then I'm going to throw out a word here that is a little technical, but it's called we need a salutogenic system. We need a system that doesn't focus on just pathogenesis. I studied from the textbook of pathology and pathogenesis. We need one that looks at what drives healing, okay? okay? What actually drives health, and have a system that focuses and is able to do that. And that means looking at the whole person in those areas, because they have to be engaged in that process.
Dr. Goodrich, I wanted to ask you about Humana leaning so much into value-based care. And we know that the success with the value-based care movement was all about influencing positive behavior change with patients, but it's had a tremendous impact on us as providers as well. I wanted to know, like, what's the most unexpected lesson that you've seen about either patient or physician behavior change when it comes to prevention or early intervention?
Well, I think it might help to sort of paint a picture, especially for your listeners, of what's the difference between sort of what I'll call traditional primary care as it has existed in this country under the fee-for-service system with what I'll call the more advanced value-based care. Value-based care is a term that has come to mean a lot of things to a lot of people. So I tend to focus on the more mature and advanced type of primary care that does get to the type of care that you were talking about, Dr. Jonas. So, and I'll use my mom as an example, right? So when my mom was alive, she saw a primary care doctor in a very busy multi-specialty practice. And this is a doctor she's had for 15 years, but it still took 6 to 9 months to get an appointment. And then when she got an appointment, half the time, not half, 75% of the time she saw her doctor, or the other 25% it might be a resident, and that was fine. She understood that was the system she was in. But the appointment would last about 10 to 12 minutes. And so we were conditioned to, before we went to the appointment, figure out what are the 2 things that we need to talk about. My mom actually had 5, but let's think about the 2 things that we have to prioritize for this appointment. And then she had 6 other clinicians that she needed to see outside of that system. Certainly no communication between them and the primary care doctor. And when she was hospitalized, it was kind of random as to which of her 7 doctors got the discharge summary. It wasn't always her primary care doctor, even though we were always very clear about who that was. There were medication errors, all that kind of stuff. Okay, let's talk about advanced primary care, what that's like for the patient and for the clinician. And by the way, my mom's primary care physician was wonderful. I handpicked her for my mom. But she was overwhelmed in a system that worked against her. And she couldn't deal with the holistic aspects of my mom's care. So in an advanced primary care model, and the reason those exist is because of the economic model that undergirds it, that allows for prospective payments to primary care practices so that they can invest in the resources like social workers and behavioral health specialists and nutritionists and pharmacists within the brick and mortar walls of the clinic, but maybe also telehealth for where that's needed, can invest in the data and analytic insights at the point of care so that you can manage the patient in front of you as well as your population of patients. That takes a different payment system. What's that like for a clinician? Well, so for our clinicians in our CenterWell clinics, which are an advanced primary care model, they have time and they have simplicity. Now, there's still sometimes frustrations. I want to paint you a picture that isn't true, but let's start with the time. They see about 8 to 12 patients a day, and they have about 30 to 40 minutes with a patient. But often when the patient comes in, they're there for a couple of hours because they're also seeing the social worker. They might even be seeing the social worker or the behavioral health specialist first. The doctor might be ancillary to that appointment because that's who they need to see for what they need right then. If they call to get an appointment, they can usually get it by the next day, sometimes same day, but certainly within a week or 2 if they need to. So there's so much attention paid to making things easy for the patient, but also easy for the clinician. Another thing is it allows, because of those prospective payments, we can actually invest in resources that make things easier for the physicians, the nurses, the PAs, the MAs, the front office staff. And I'll just give you an example of 2 of those things. One is ambient AI. You may have heard of this. This is a technology that is gaining in popularity because it is making people's lives easier, that allows a clinician to effectively record the visit between them and the patient, and often the patient's caregiver as well. And at the end of that visit, I'm going to make this sound really easy, but it does feel magical. It spits out a note in the SOAP note format on the other end that the clinician then goes and just reads and makes sure is accurate, may have to make a change or two, but it's actually pretty darn accurate. I've seen this work in real time a number of times. That really has significantly reduced in our clinic, we've been measuring this, certainly pajama time at the end of the day, but also burnout. It's not the only solution to do that, but is an important one. And then the second one is another type of technology, which is AI-based, to allow the clinician to have, before they walk into the room to see the patient, all the information about what's happened to that patient since they were last in their clinic. Were they hospitalized? What happened at that hospitalization? So with access to various data sources, the technology can pull together as much information as it has access to about the specialty visits they had, about the lab work that they had, about whether or not they got their medications picked up. So that way the physician walking in doesn't have to go hunting and pecking for the latest hospitalization or did they pick up their meds. It's actually right there summarized for them. It's still hard to be a PCP even in those circumstances, but it gets you from that 26 hours a day closer to the 9.
Dr. Shin, I wanted, you're in the world of data and community health. What's a hidden statistic or trend about chronic disease or primary care that leaders in Washington, D.C. need to understand, but they don't?
Well, let me preface the answer with just talking about the health centers a little bit. And that is, there's about 1,500 health centers across 16,000 communities. We serve about 32.5 million people, which is about 1 in 10 in this country. And to your points around, whole person health and patient-centered care, when a patient comes in, we do screenings for not only the chronic issues, but also those conditions or circumstances that contributes to those conditions, really the social determinants and the social drivers, and really gets at really understanding, what it's going to take to address those major issues. Now, I think one of the things, we try to always talk about is prevention, right? So the ounce of prevention is worth a pound in cures, right? So I think one of the things that we have been looking at is some of that data, looking at, how much goes up in terms of prevention counseling. So for example, for hypertension, it could be like just a few $100s, but down the road, it's about $2,000, and then once they become hospitalized, it could be hundreds of thousands. So we just try to tell that sort of cascading story of what it means to be treated or untreated, to have control or no control, and really the importance of not only clinical care, but really, again, sort of looking at, what are those conditions that are feeding that. And so I think, one of the examples we love to talk about is, when the first health center was created 60 years ago by Dr. Jack Geiger, he was billing the federal government for food. And they came down and said, what am I supposed to do with this? And he said, well, I think as a clinician, the cure for starvation and poor nutrition is good food. So, that's the kind of things he was prescribing. So, I think in terms of just being able to look at the person's health issues, their social issues, as well as their behavioral issues, is a critical and vital component of what we're trying to think about. And I think the health center model is not just about being in the underserved or serving the underserved. I think the chronic condition is a defining condition for primary care. We are really in the throes of really trying to think about how to address that up front. We're not abandoning it in any way. And so I think, as we're thinking about multidisciplinary approaches, team-based care, and really trying to think about, how do we get at these effective solutions in a very cost-effective manner, I think that's something I think we are all trying to get on board and really thinking about honing that message of what it means for prevention, what it means for cost down the road, and that we are all in this game of really providing value to what people will say is a value-based system.
Dr. Brodine, what gives you hope when you're looking at the next generation of our primary care clinicians, especially those who are stepping into some of the neediest communities?
Yeah, I'm very privileged to have the honor of working with some phenomenal medical students and residents that rotate through the clinic where I work. And as I've been in healthcare since 2003, so I feel like I've seen a lot of different generations of future leaders, future doctors coming through. And as I work with folks that are coming into it, new residents about to become new family doctors, I get a tremendous sense of hope as I understand something that I might call like a generational spirit that I think is new and different than what I experienced when I was their age. And I think about the fact that they're very focused on not only taking good care of their patients and practicing good evidence-based medicine, but they also want to address underlying inequities through health. They want justice through health. And I love that, and I celebrate that, and I think that that's a new way of thinking that I don't exactly remember seeing in the same way. I think it's existed from many great leaders in the past, folks who knew that the prescription for hunger was food. We know that there's been always good inclination towards social justice. I think Foucault said physicians are the natural attorneys of the poor. So that's always been part of our credo as physicians, but I think there's a social consciousness that seems particularly well honed in this generation of up and coming physicians that gives me a lot of hope. My only caveat is I hold on to that hope so long as I have confidence that we have mechanisms in place to foster that ongoing pipeline of talent coming into medicine, that we're looking to communities where there are health provider shortages and saying who in this community can step up to become a physician, where we're making this a priority in our medical schools to go towards primary care, where we're incentivizing people into careers that say primary care is worth it, both in terms of your heart and also just being able to get through and have a good life, earning a living. I think that's part of what we need to do. We need to make it a good and safe career so that the right people really embrace the right kind of medicine.
Yeah, I had to agree with you that the interactions with this generation of residents, like their focus on the doctor-patient relationship, it is incredibly refreshing. Dr. Jonas, you've championed integrative and lifestyle medicine now for years. So why do you think that those breadcrumbs of prevention and whole person care haven't turned into the main course yet?
It's fascinating when you take the board exam, which I've done I don't know how many times now, and there's a question about what is the best approach for name the chronic disease, okay? Diabetes, hypertension, obesity, heart disease, etc. And if one of the answers is behavior and lifestyle, that's the correct answer. But guess what? The next 7 questions are all about which drug to prescribe. And did you do this drug or that drug, or which procedure to do? And that's because those are the tools we have, because that's where the money is invested in terms of the research. Now, lifestyle medicine is a sword hanging over the head of every physician, not just primary care, because we know that 60% or more of the chronic diseases actually have their root causes in lifestyle. And yet, all you do is you answer that question, and then I don't learn actually how to make the change, nor do I have the resources to do that. So that sword is dropping right now, and I think the current administration is trying to say that, okay? I don't know if they actually know how to do it, but they're trying to say that. And so we should be leaders in that area and design a system that hits at those salutogenic components that not only prevent chronic disease, but in many cases can reverse it. And that's what's really going to drop and save costs. But if you don't get paid for doing the research to give you the tools to do it, and you don't get paid for delivering it, then it's going to be sitting there over your head until the sword drops.
Yeah, I have a family member I was speaking with last night who was feeling so secure about his blood work. Now he's obese on 5 different medicines, and his blood work looked fantastic, but he can't bend over to tie his shoelaces.
Exactly. All you got to do is take a statin and you've solved your heart disease problem, right? Okay, just get that LDL down and forget the rest. It's about it's the Osler versus Flexner issue. Is it about the numbers or is it about the person? And we've decided it's about the numbers, and we now pay for the numbers instead of the person. We need to shift that.
I'd like to open this up to the panel. There's always been this tug of war between doing what's right and what we can afford. So, but we've heard it loud and clear. Investing in primary care saves money. But why isn't that message breaking through?
I can take a start. I think it is I think there's more people listening to that message than they have before. I think that there are groups out there, including some who are represented in this room, who have been very consistently and effectively making the case. And let's look at even what's been done by the Innovation Center over the last several years. There actually has been progress made in trying to change how we pay for things in order to have an economic healthcare system that supports the kinds of things that we've been talking about. So we shouldn't say that there's been no progress, but it is still, I would argue, relatively early in what is probably like a 50 to 70 year journey, frankly. So it feels like there hasn't been as much progress. We're at a point where we have to really accelerate the things that we know work. And so where you have seen that investment in the models I was talking about, by the way, I'm a huge fan of lifestyle medicine, not just because it's like a fad, because it's not, it's because the evidence is striking about its effectiveness. And the care model that we have in Centerwell, and actually lots of other organizations have as well, that advanced primary care model that I mentioned that exists because of value-based care payment system, actually facilitates the delivery of lifestyle medicine, because it does allow for the time, the training, et cetera, to be able to do that. So I don't think there has been shock and awe moment of suddenly we all realize we've been doing everything wrong and we just suddenly got to change things. But I do feel like we've had some successes. There are more and more voices, and there need to be even more about how, if we're going to fix or make a dent in this chronic disease problem, we have got to fix the underlying payment mechanism for primary care, and not just the payment. We got to be sure we have the right clinical models. We know how to do it well, that we can do it well with, it may not look exactly the same for everybody, but there's a lot that's going to look the same, and really be able to support that. So I'm a glass half full person at heart, but I do truly see some receptivity from our policymakers, both on the Hill and at CMS, to making some of these moves. So I actually am positive.
Actually, I was also looking at Dr. Brodine, because we were talking about this a little bit before, about, it's like when you have patients and they're like, well, nothing happened when they see their visit. So, how do you get credit for that? But the other thing being that, there's been tons of studies around the cost savings that primary care generates, a real value. So value being defined for payers, like the total cost of care savings, for providers in terms of outcomes and their own experience and satisfaction, and for for patients in terms of their own experience and good outcomes. But, at the end of the day, it's, health patients feel the shortage. They feel the wait list that they're having to be on, the wait times, the challenges of getting that appointment, and then when they get in, it's quick and turnaround time for them. They don't really get to experience what they should be experiencing in terms of having that full 29-hour time with them. So I think, if there's a way that we can get the patients and the consumers really to advocate and understand what that experience should be like, and that their experience and that what they're seeing as like nothing happened is really part of that experience. I think that also goes a long ways in terms of providing a greater perception of the value of primary care.
I think you didn't quite go far enough in your question. The question really is, saves money for who? Because the slide that Dr. Brodine showed, where most of the money is going into the hospital systems, if we really prevented and reversed and managed chronic disease better, we would save money for the system, but they would lose money. Okay? And so there is an internal conflict within healthcare that are pulling in different directions in those areas. And that has to be looked at head on for the country as a whole and for the individual patients that are suffering and need the kind of care we're talking about. So
we see all the time with patients going to a clinic thinking that this is a doctor's clinic, and they have no idea that it's a hospital-run practice. Well, let me ask you, Dr. Jonas, if you had a few minutes with the president or CMS leadership, how would you make the case, quick and clear, that addressing chronic disease through primary care ought to be a national priority?
I would say making America healthy again is a great effort, and reducing chronic disease is super. Let's make sure we put the investment where it's going to do it. Okay? Cut the rest. And guess what? There's a whole plan laid out how to do that. And it's very systematic. It's thought through. It was published by the National Academy of Medicine several times. And it said the investment should be removed from here because it doesn't produce health. It's not evidence-based, et cetera. And it should be put into there. And if you do that kind of shift, you will see people flourish and the wealth of the nation will grow because we'll have less need in those areas. And so that's also making America great again, right? I think. So that's what I would tell them. I wouldn't go any further than that.
Dr. Brodine, you know, if we do this right, if we embrace the technology, we embrace the ambient AI, and now we've got this movement that's, you know, focusing on the 60 to 80% of the the lifestyle changes that impact the modifiable health outcomes, like what Dr. Jonas said, 60 to 80%. What do you think America's health story will look like 10 years from now?
Yeah, I think if we're able to steer hard in that direction, I think we're going to see an inflection in terms of the trends that I was describing earlier. I certainly think it depends heavily on really everything that we've been talking about. You know, I think Dr. Jonas is right to point out that, you know, we have to identify what are we talking about when we say primary care? You know, what does that mean? How does that look for people? It is rooted in the relationship. And, you know, I think when Dr. Goodrich mentioned about the excellence and experience in value-based care, my organization, I help oversee our involvement with the Maryland Primary Care Program, which is part of Maryland's total cost of care. It has been a game changer for our physicians because instead of going at it alone, they have care managers, a pharmacist, navigators, community health workers, a group that helps focus on cancer screening specifically, all of these resources that can really help them take good care of the patient and free them up to focus on what's most important in working with these patients, which often is managing chronic illness. And I think, you know, Dr. Shin, you mentioned about the patient's experience. I think that's what it would look like, is that a patient can say, I know who my doctor is, right? It's almost like a predictor. It's like a measure, a leading indicator of health is I know who my doctor is and they know me. And I think that we'd have that relationship very well established, and it wouldn't be just restricted to a bricks and mortar location. It would be electronic, it would be virtual, it would be part of someone's device. It would be part of how they plan their year and their time and their priorities. And it's safe to talk about health because we're talking about promoting wellness and producing health. So I think that is the vision that we have to work towards.
Dr. Goodrich, for you, like what's one bold but doable change that we can start tomorrow? It's the middle of the week, it's Wednesday, either in a clinic, for Dr. Brodine this afternoon, a health plan, a policy room, that would move the needle on chronic disease in a real palpable way? I
think you gave me the hardest question. I don't know that there's anything that you can do in a minute, but maybe one aspect that we haven't touched on quite as much yet, and I don't know what the thing to do in a minute is to get to this, but it's, I think, a really important piece of it is how do we make healthcare simple for people? And if I think back to my mom, and if she had an acute problem, she wasn't going to go to her doctor. We had to go to urgent care. We had to go to the ER. And I know better. Like, as a policy person who worked at CMS for 10 years in Humana. So healthcare is so hard for patients and caregivers in their highest moments of vulnerability. That is so striking to me. They're scared, and everything about the system puts up a barrier. Right? So I would start thinking about, if I were you in your clinic or me at Humana or anybody out there, what is the one thing that we can do for our patients that will at least take a little bit of edge off that burden for them? What are process flows that we can just simplify? There are big things we need to do to make healthcare simple, big things that are going to take years. There are medium-sized things that we at Humana, you and your clinic, have control over that we can spend time trying to simplify. But there's probably also some little things that, if you take it from the viewpoint of the patient and what they're experiencing, that you can simplify in your clinic that might just be a little delighter for that patient or that caregiver. that we should be thinking about.
I'd like to thank you all for your insights, taking the time to come over here to Washington, D.C. for this panel. I invite our listeners and our viewers to take actions in your own spheres, in your own clinics, in your own communities.
What are your thoughts on addressing the chronic disease crisis, the foundation of making America healthy? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.